Mistakes are a fact of life, but in the medical world, especially when a patient's life hangs in the balance,
I now declare this hair transplant officially over. Oh my God, one of my patients on 2 has been shot.
we do everything we can to avoid them. I and many of my colleagues work together as diligently as possible to help our patients overcome obstacles and walk away happy and healthy, because you matter to us. And yet, despite our best efforts, it doesn't always go down like that.
We did all we can, but medical science has come just so far.
Surgery is inherently dangerous, while diagnosis, other treatments, medication, and rehabilitation come with their own unique challenges. Worse yet, some medical professionals simply do not have their patient's best interest at heart.
Relax, I'm a doctor. Ha 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 ha!
Horrifying, I know, and between mistakes and malpractice, I've heard my fair share of real-life horror stories. So for once, chiropractors can rest at ease, because today they're not catching the heat.
A lot of impact.
Yeah. You ain't seen nothing yet.
Today, I'm looking at some of the worst doctor horror stories. Buckle up, interns, because it's gonna get toasty up in here real quick.
I need to get out of here. I need to get out of here. I need to get out of here.
Some of you may already recognize the patient in the clip, Matt Caswell, a patient prepped to undergo routine surgery at St. Charles County Hospital in Missouri in July 2020. Doesn't take a detective to tell you that his surgery was anything but routine. Caswell expected to drift into an unconscious state before his surgery, but that did not happen. Instead, he felt the surgeon cut into his stomach.
I just got stabbed in my stomach. It was just like rusted razor blades.
There was a towel over his face, and he was unable to speak because he had already received an initial paralyzing agent before surgery. During surgery, there are several different agents that anesthetists use to perform different tasks. The most important of these agents include inducing agents that are used to put a patient to sleep or make them unconscious, sedatives that are used to provide various levels of sedation while keeping the patient awake, paralytics that are used to reduce or eliminate muscle tone and response so that it is easier to perform certain surgeries, analgesics that provide the pain control while the surgery occurs, and reversal agents that are used to restore alertness after surgery has ended. The various combinations of drugs that are used is determined by the anesthetist experience and comfort level, the type of surgery being performed, and the surgeon's requirements.
I knew I was in trouble when I felt the cold iodine hit my belly, and they were scrubbing me off.
Caswell attorney Ken Volstecki told local news that the anesthesiologist forgot to turn on the gas that would make him fall unconscious. Oh, ouch. Caswell actually said that at that moment, the pain was so intense that he wished to die right there in the surgery room. The psychological trauma of undergoing surgery without anesthesia can be long-lasting and lead to post-traumatic stress disorder, or PTSD, and other mental health issues. I mean, just think about it. That is why anesthesia is crucial to ensure the patient's comfort and safety. But while it may be true that the anesthetist forgot to turn on the gas that maintains unconsciousness, it would be extremely unlikely that a patient would be paralyzed without first being rendered unconscious, as that is the normal progression of events. Put them to sleep, then paralyze, not the other way around. And your response to the painful stimulus of surgery would be instantly recognized by the immediate change in your vital signs on the monitors. Both heart rate and blood pressure would immediately spike, causing everyone within eyeshot and earshot to take notice. Like, yikes. So we're off to a great start, or terrible, depending on how you slice it. Let's see what else my team has prepared for us and if it can get any worse. This story comes to us from a Redditor by the name of Mrsvillianous because, well, where better to begin than the Ask Reddit thread. When I was 12, I tore my rotator cuff on a screwball playing competitive fast pitch. Although a rotator cuff injury is rare in a person of this age, with the right stimulus, such as with a high-speed pitching mechanism, it is possible that the rotator cuff could be torn in this manner. At the time, we weren't sure what exactly I did, so we went on to the specialist at my doctor's office and he decided I needed an MRI. He decides he specifically wants to do an arthrogram where they fill your joint with magnetic fluid so they can more easily see what's going on in there. Also a fair thing to do. When reading these posts, I have to remind myself that these are the words of a layperson who may not fully understand what is being said. An arthrogram is a diagnostic radiographic procedure where a joint is infiltrated or injected with a dye that is radio-opaque, meaning that it blocks X-rays. This dye will move into all the small spaces within the joint, and when imaged by magnetic resonance imaging, or MRI, will provide more clear imaging of subtle or fine details than would be possible with a plain MRI. An arthrogram can be done with regular X-rays, CT scans, or MRIs, depending on what the physician is looking for. Not fair, however, was having his trainee do the injection procedure on me and refusing to give me anesthetic. Let me paint a picture for you. The needle was at least 6 inches long and very thick. The joint capsule inside which the dye must be injected is actually fairly deep within the shoulder. There are at least an inch or an inch and a half of muscle tissue between the skin and the inside of the shoulder joint. So usually we will use a needle of at least an inch and a half to inject the shoulder joint. A needle of 6 inches in length would be relatively uncommon, although in some instances they do use spinal needles, which can be about 4 inches long. The diameter or gauge of the needle is determined by the thickness or viscosity of the fluid that is being injected into the joint. She puts it in my shoulder and doesn't know what she's doing. So the needle starts dragging across my tendons and ligaments, twanging them like she was plucking a guitar string. She's just poking around blindly, hitting whatever is in her path. It was so painful, I had to bite my thumb to keep from screaming, and I actually bit through it in the process. My mother asks him why the anesthetic isn't working, and he just tells her he didn't give me any because he didn't think I would need it. To be honest, this is not as shocking to me as it sounds to a layperson for several reasons. First, the anesthetic. While it is certainly possible for us to give local anesthetic for injections, local anesthetic has been shown in several studies to be chondrotoxic or bad for the cartilage in the joint. Consequently, it is a doctor-specific choice of whether or not to include local anesthetic in a joint injection. Some physicians will use it, others will not. In my case, I might inject the skin with local anesthetic first, and then introduce the dye injection needle separately afterward if I thought there was going to be an issue hitting my target. Second, while nobody really wants to hear this, all trainees need to learn how to do procedures so that they can become competent at them. This means doing them when we don't know what we're doing.
Just relax, Mr. Swanson, and let the anesthetic do its job.
All right, Doc, I trust you.
Now I'll just pop in the how-to video and we'll get started.
All of us were at this stage at some point in our training. We gain experience in these tasks and become better at them by doing them repeatedly and learning from our mistakes. I know, it sounds brutal, but we all have been there, myself included. The injection ends, and now I have to go lay completely still for 45 minutes in the MRI machine, even though everything still hurts so bad I'm literally writhing in pain. They had to redo the MRI twice because I was moving too much. Now, once the dye is injected, the worst is actually over. Unless, of course, you are claustrophobic. Then it's just beginning, bro. An MRI can take anywhere from 15 minutes to an hour, depending on what area of the body is being studied and what particular views the requesting physician wants. You have to remain still for the duration, and the machine itself is quite loud, with whirring, buzzing, and banging sounds occurring throughout. All of this happens while you are laying on your back in a narrow tube with the body part being investigated, clamped in a jig.
It's just so small. It's bigger than it looks.
Not the most pleasant thing if you are already in pain from the injection procedure itself.
Actually, Candace is very peaceful. It was a torture chamber. I was in there 1 minute and I cried.
Now, imagine being admitted into surgery to remove your appendix and, despite receiving appropriate anesthesia, having a whole other organ removed instead. That is exactly what happened to a man named George Piano in Washington, D.C. George visited the University of Washington Medical Center emergency room for abdominal pain, and after being diagnosed with appendicitis, was taken into surgery so doctors could remove his appendix. Generally, the diagnosis is made from the history and physical examination, and then further corroborated by imaging, which usually includes an abdominal X-ray or ultrasound and a CT scan, as well as diagnostic blood work. But during the surgery, the patients were unable to locate the patient's appendix and instead removed a part of his bowel. Oh, damn. If you have a ruptured appendix or a very inflamed appendix, there might be significant scarring around it or adhesions between it and the surrounding tissues. Nearby tissues can be very hard to distinguish from one another, making their dissection, when required, extremely difficult. The appendix is found at the junction between the small and large bowels on the right side of the abdomen. If there is a significant amount of inflammation present, it can be extremely challenging to tell one structure from another in this setting. It would be relatively easy to mistake one problem, say for example a ruptured appendix, for another, like say a ruptured diverticulum. Following surgery, Mr. Piano began to experience abdominal pain, which was worse than before his surgery. The bowel contents began to spill into his abdominal cavity, causing him to become much sicker. This would be as a consequence of developing sepsis. Generally, the bowels contain food in various stages of digestion. The further along the digestive tract you go, the less the contents resemble food and the more they resemble stool. The large bowel, where diverticulitis generally occurs, is largely filled with stool, and here the bacterial count is quite high. While the body can tolerate these high bacterial loads when they are contained within the gut, it is another thing altogether when stool and the accompanying bacteria spill out into the normally sterile abdominal cavity, where they can cause grave danger. According to the lawsuit, a doctor removed a piece of diverticulitis on Piano's lower colon, not on his appendix. And he needed another surgery to repair a leaky colon and address an abdominal infection caused by the surgery. If there is a rupture of a portion of the digestive tract, or if a portion of the bowel must be resected or removed, the bowel can be reconnected or repaired immediately, or in a delayed fashion if there is evidence of concurrent infection or a likelihood of ensuing infection. Occasionally, after a repair or a reanastomosis, where the bowels are reconnected, there can be some inadvertent leakage from the locations where the individual sections were reconnected. Piano said that over the last year, he has spent 53 days in the hospital, lost about 40 pounds, has anxiety, and has suffered short-term memory loss as a result of the alleged medical mishap. Given the complications and the additional hospital care that can be associated with this type of recurrence, all of the issues that Piano complains of sound possible and reasonable. I am a bit skeptical about the short-term memory loss, but with extended hospital stays, it is not unusual for the days of extended stays to roll together, and without regular exposure to the sun or the outdoors, it is possible that there are stretches of time where nothing memorable occurred while he was in hospital. It is also possible that extended or recurrent sepsis could have an impact on his cognitive function, including short-term memory. But wait, that's not even the worst horror story. It gets worse. Some mistakes can be even more dangerous and destroy an otherwise healthy person. Sadly, this was the case for a Redditor who goes by the name of Admiral Thanks 980. Cut a nerve on some glass several years back in my right hand. Was stitched in the ER, but missed the ulnar nerve, was lacerated. Developed painful neuroma from the nerve injury. When a nerve is lacerated or cut, a scar can form at the end of the nerve, where the injured nerve starts to heal in an uncontrolled manner, producing a lump of unorganized axon fibers and non-neural tissue. These neuromas can be sensitive and painful, particularly where there is pressure on them. Any type of trauma can result in the formation of a neuroma, including surgical trauma, blunt force trauma, nerve transection or laceration, or chronic inflammation. I was referred to pain management, and they took advantage of my insurance and opiate epidemic. So they made me do steroid cervical epidurals because they made so much money off them. Cervical epidural injections of steroid is a technique that is used to relieve inflammation in the neck associated with cervical disc pathology or degenerative arthritis of the cervical vertebrae. It involves injecting corticosteroid anti-inflammatory medication at the site of the inflammation to allow the reduction or even the elimination of pain symptoms associated with the inflammation. When effective, these injections, although limited in duration, can eliminate pain, upper extremity numbness, tingling, burning, and even weakness in the involved extremity. The injections never helped, and on the fifth one, they breached my spinal cord and injected particulate steroids into me, giving me a spinal cord injury in my neck. Immediately paralyzed the left side of my body. I was 25. I spent 3 months in the hospital and rehab and still am in an outpatient physio to this day. It is very unfortunate that this injury occurred. Normally, when these injections are performed, the steroid is injected into the epidural space around the areas where the inflammation is present. It does not normally enter into the spinal cord itself, but rather into the space around the cord. Injection into the spinal cord is a rare but extremely dangerous problem. This can cause severe injury to the spinal cord itself that can result in pain, numbness, or paralysis of nerves that travel beyond the site of injury. If the needle itself or the injected contents of the syringe caused significant damage, then permanent paralysis is certainly a real and tragic consequence that can occur. Ruined my career as an EMT firefighter, obviously. Lost the use of my left arm and leg. Gave me a lifetime of severe chronic pain. A neurogenic bladder, so I can't pee on my own. PTSD and anxiety. Also, remember, my right arm was in pain, so that's why I was there in the first place, but now that's all I can use. 3 years into the case. These are all very unfortunate issues that arose from this simple, seeming innocuous procedure. It is a rare but devastating injury that can occur as a result of carrying out an invasive procedure in close proximity to neurological structures. The combination of issues that the poster describes occurs as a result of a rare neurological condition called Brown-Sequard Syndrome. This condition is characterized by an injury to the spinal cord which results in weakness or paralysis on one side of the body and a loss of sensation on the opposite side. Although it can occur by a number of mechanisms, it can be caused by a puncture wound to the back or neck. Because it is a rare disorder, there is not a lot of information related to it. Generally, its prognosis is dependent on its initial cause. Most people regain some function over the months that follow the injury. However, after 3 years, it is unlikely that this poster will regain more function. To be honest, this is an unmitigated disaster, and my heart goes out to this patient. As physicians, it is always important for us to be aware of the risks and complications that are associated with a particular procedure, and we must always weigh the potential benefits against the risks and complications to make sure that we are using the safest procedure to achieve the desired results for the patient. Another important thing that I frequently tell patients is that while the complication rate for a particular procedure may be only 1% or less, if it happens to them, it's 100% because it happened. While most complications are fortunately rare, their consequences can be extremely devastating. The poster later discovered that the procedure was performed by radiology techs who were working outside of their scope of practice and improperly trained, rather than by the radiologists themselves. This poor decision resulted in a lifelong injury with permanent consequences. Wow. That was certainly intense. It makes me wonder what this person will miss out on because of one doctor's poor decision making. As for our next patient, no one needs to wonder. You'll understand in a second. You probably heard that one of the long-term complications of diabetes is nerve damage or diabetic peripheral neuropathy. If left untreated, the damage can potentially lead to chronic wounds, infection, and limb amputation. A big fear among diabetic patients. So try and wrap your head around this next disaster. Losing both feet when you were only scheduled to lose one.
You know what? If we come across somebody with no arms or legs, do we bother resuscitating them?
Because of a paperwork mishap.
I mean, what kind of quality of life do we have there?
That's exactly what happened to Willie King, a 51-year-old suffering from diabetic complications, which resulted in both feet being severely diseased. The foot that was not scheduled for amputation did not look healthy, and the surgeon wasn't surprised by its condition when Willie arrived in the operating room. He saw a diseased foot, prepped for surgery as expected. It was just the wrong one. This is a problem in the operating room, particularly for people who have pathology that affects both sides. In fact, it is one of the leading causes of surgical malpractice. So much so that we have developed a surgical pause that is a regular part of every surgery that is performed in the operating room, or at least it should be.
Okay, if we can get an all stop for our pre-procedure timeout. Luna Lovegood, medical record number 01234567.
Matches my chart.
We are consented for left thumb replantation versus revision amputation.
That matches the consent.
A surgical pause is basically a timeout before the procedure has started, where everyone in the room stops what they are doing and everyone in the room checks and agrees that we have the right patient present for the right procedure on the correct side, using the proper instrumentation, implants, and medications for the arranged patient.
All right, thanks everybody.
This practice has been shown in studies to significantly reduce the incidence of avoidable errors in the operating room. Unfortunately, here, someone listed the wrong foot on the paperwork, and so the wrong foot was prepped for surgery. The blackboard in the operating room, the OR schedule, and the hospital computer system all said the same thing. However, the consent form and medical history noted the correct foot. Because there are many people involved in making surgery happen, it is possible that simple transcription errors can be introduced and subsequently propagated through the system by any one of these people that might include the clerks in the operating room, the admission clerks in the hospital, the surgical nurses, the daycare nurses, the recovery room nurses, the surgeon, the anesthetist, among others. Any one of these people, or even several of these people, could have made the error or even made several errors, particularly those, such as the clerks, who are somewhat separated from the procedure itself. This fact underscores the importance of the preoperative pause and identifying and marking the limb with the patient before surgery. The paperwork, the consent form, and medical history were available in the operating room, but there was no requirement at that time for the surgeon to check it prior to surgery. Additionally, the surgeon didn't speak to the patient before surgery, so they weren't able to communicate directly and hopefully catch the error. It is good practice to arrive early so that you can talk to the patient prior to the surgery in the pre-op holding area. This gives you a chance to refresh your memory of the patient, for you to go over the consent again, discussing risks and complications, and for you to identify and mark the operative limb under the patient's gaze. Well, interns, there you have it. Believe it or not, the list my team provided is much longer. If you're interested in another video like this, let me know in the comments down below. And if you have any doctor horror stories to share, please share them with us in the comments. If you enjoyed the video, be sure to subscribe and give it a big thumbs up to feed the algorithm. And if you're already subscribed, make sure that you weren't unsubscribed from the channel by the Illuminati. Our next goal is 700,000 subs, and we would love to have you with the squad when we get there, because my squad rolls deep. And if you don't like the video, be sure to let me know why in the comment section down below. I read as many comments as I can, and we use your feedback to make our videos better for you. For longer form content of an interactive nature, consider checking out my podcast channel, where I interview interesting personalities in the health and movement space. And don't forget to follow my gym, Human 2.0 Fitness, for free right here on YouTube, where we post content that helps you move better and prevent injury. Or check out Human at Home, where we teach you how to live healthily in your home, because not every person can access a gym that's like ours. Otherwise, as always, that's been a word from Dr. Chris, not your everyday ortho, where we see one, do one, teach one.